Okay, we're going to move on to our next speakers. I stole a little bit of their time because they're part of our team here at PCRM, so thank you so much for your understanding here. Diane, Salema, and Jessica Mackie are both genetic counselors, board-certified genetic counselors who work with PCRM, and they're going to talk to us about private pay genetic testing, what's new and what's missing. So I'll ask you to go ahead and share your screen.
Okay. There we go. Can you see and hear okay?
Perfect.
Perfect. Thank you so much, Dr. Dunn. Yes, Jessica and I are excited to talk to you all about private pay genetic testing. This is a talk that we gave at the PCRM Symposium a few years ago, and so we tried to reflect on what has changed in the last few years and what the landscape looks like now. So that's our only disclosure to report, is that we are both employed by PCRM. We have no other disclosures. Like I said, we're hoping to review with you today the changing landscape of the behemoth that is the private pay genetic testing market. We want to spend some time talking specifically about expanded carrier screening. That's really relevant to our practice. And then hopefully leave you with some genetic testing resources for you and your patients. So let's start by situating ourselves. What kind of testing are we talking about when we say private pay? We could be referring to lots of different things. Expanded carrier screening, a type of testing used to tell a patient or a couple about their risk of having a child with a specific condition. Pharmacogenetic testing. This is a relatively new area of testing, but has to do with looking at individual genetic variants that tell us about how we metabolize drugs or medications, how we respond to different drugs to help with guiding prescriptions and dosages. Or maybe we're talking about testing for genes associated with an increased risk of developing cancer or cardiovascular disease. So how might a patient access this kind of testing? Well, it might be ordered in a traditional way in a clinical setting, initiated by a healthcare provider, but maybe it's paid for out of pocket because the individual doesn't meet the criteria for MSP covered or provincially covered testing. In a very different way, it could be marketed directly to the consumer and bypass involvement of a physician altogether. So direct to consumer or DTC genetic tests, we think of like 23andMe and Ancestry. It could be a hybrid of those two things. Maybe it's something that the consumer or the patient initiates the request for testing, but it has to be signed off on by a physician in order to be processed. This is a little bit different, but kind of related. Sponsored genetic testing refers to testing that would normally be paid by the patient out of pocket, but it's being sponsored or covered by a biopharmaceutical company or a genetic testing lab, usually in exchange for access to that genetic data. So obviously we don't have time to go into all of these different areas today, but just to give you an idea of the scope of this topic. So why would it be more common for people to be accessing genetic testing that they're paying for privately? I think first and foremost, people are interested in it. There's a growing interest for people to seek out their own personal genetic information. The costs of a lot of these tests have been decreasing over time, making them more accessible. And there's also a cultural trend, not just here, but in many areas of our society, towards self-sufficiency. This idea that you don't need a specialist to do something, you can figure it out and you can do it yourself and take it into your own hands. And the traditional method of accessing genetic testing, when it's funded, there are a lot of access issues with our current model. There may be a lot of people who don't meet criteria for funded genetic testing. Maybe they don't have a strong enough family history of cancer to get that testing covered. Or maybe they do meet criteria, but they don't get referred to the right place for it. A lot of people in BC don't have access to a primary care physician. That's an entirely different problem. Or maybe they do meet criteria, they do manage to get referred, but there's limited genetic services in the province and they're on a 1 to 2 year wait list to get an appointment with a genetic counselor or a geneticist. And then geographical barriers will always play a role in access too. I wanted to spend a few minutes on the direct-to-consumer genetic testing industry, DTC for short, because for better or for worse, I think this is what a lot of people think of when they think of getting genetic testing done, accessing their genetic information. So we're talking about your at-home DNA tests, 23andMe, Ancestry, spitting into a tube at home, sending it off to the lab, getting a report back by email. So these companies emerged in the early 2000s as a means for consumers to access their genetic information without involving a physician. These companies promise to provide you information on not just your health and wellness, but also things called traits. So things like how athletic you are, whether you like cilantro or not, the type of earlobe attachment you have. And then they would also tell you about your ancestry, not just likely what your genetic makeup suggests for where your family comes from, but connect you with other users who are genetically related to you. These quickly became popular in the 2010s, although being controversial in medical and regulatory circles. From the get-go, there have been concerns about the accuracy and reliability of these results, as well as whether the advertising is misleading to the public. Despite that, public regard is generally positive. Most people support having access to these tests. An unintended consequence of these tests came through the genetic relative finders. There have been so many reports now of people who discovered something about their family through doing these tests and being connected to other people they're related to, finding out things they didn't know about their family, often things that are disruptive to the family. So finding out that who they thought was their biological parent is in fact not, finding out about a sibling they did not know they had. And sometimes these discoveries led to other more unsettling discoveries about the sources of those relationships, sexual abuse and incest. So really disruptive information, again, for better or for worse, has come from these. But they remain very popular. As of 2019, 15% of US adults had taken one or more of these tests. So I'm sure many of you in the audience have had a patient tell you they've done this testing, ask you about their results, or maybe you yourselves have done this testing. So what is new with this market, this industry, since its initial rise in the early 2000s and 2010s? Well, in 2013, the FDA sent cease and desist letters to several of these companies asking them to stop marketing these products without proper regulation. And that spurred 23andMe to start conducting validation studies and research on user comprehension. So proving to the FDA that their consumers could understand these reports and that at least some of these results were valid. In 2017, the FDA approved a subset of 23andMe's tests, those that had more of an intended medical purpose or impact on healthcare. So not whether you like cilantro or not, indicating a better separation between health information and entertainment. To be clear, these are still not considered diagnostic tests. They don't meet clinical standards of care, but they do have this authorization now that speaks to consumer safety and test effectiveness. Fast forward to 2023, and there was news that hackers had accessed a large amount of data from 23andMe and were selling user data, including people's names, on the dark web. This affected almost 7 million people, and it took 23andMe a few months to realize that the data had been stolen. This all culminated in a class action lawsuit just last month in September that settled for $30 million. And then just a few weeks ago, the entire board of directors at 23andMe, apart from the CEO, resigned, citing disagreements with the CEO's plans to take the company private, which raised even more concerns in the public about data privacy. So things are not looking good for this company. This is just a snapshot of a Google News search from 4 days ago, showing what's going on with this company. Another thing that I read was that despite earning really high revenues, they've never actually made a profit, and the stock price has been declining since 2021 and is at an all-time low. So that's what's new with this industry. What's missing? Data protection, clearly, data privacy. Clinical utility still remains something that is missing. And for this, I have an example to illustrate what I mean. So let's say you have a patient, Jamie, who's 35 years old. She's healthy. She has 2 young children. She has two older sisters as well. And she has an aunt on her father's side who had breast cancer at age 40, but she's doing well now. She's in her early 60s and living. Grandmother on this side also had breast cancer, passed away from it at 51. Grandfather died of lung cancer at 60. He did have a history of smoking, though, so that's the explanation there. Jamie's father's healthy. He's never had cancer himself. He's 68 years old. But Jamie and her two sisters are starting to get a little bit worried. They are now around the age of their aunt when she was diagnosed with breast cancer. So they are wondering about whether this is something they should be concerned about. Well, look at that. Jamie's partner gifts her a 23andMe kit for her birthday, and she thinks, great, I'm going to take a look at some of this health predisposition information. So she takes a look at the part of the report related to risk of developing breast cancer and ovarian cancer, the part that looks at the BRCA1 and 2 genes. And she's reassured no variants are detected in either of these genes. Well, hopefully Jamie also reads this part of the report. This test only included 44 out of the more than 4,000 variants that we know of in these two genes that are known to affect their function and therefore increase a person's risk of cancer. Now, to 23andMe's credit, this is a huge improvement from a few years ago. They used to only test for the only test for 3 variants, the 3 that are most common in the Ashkenazi Jewish population. So great screening test for someone of that background, not useful for anyone else. This is a little bit better. This is still very narrow and limited. So let's say that Jamie's aunt decides that she wants to do some testing. She has children too. She wants to know if there's anything for them to be aware of their own risks. She ends up getting genetic testing done, ordered by her physician through a clinically certified lab that does gene sequencing rather than targeted variant analysis. She gets her results back and finds out she has a BRCA2 gene mutation. This explains the cancer at a young age for her. This is something that her family members can now be tested for to see if they inherited this as well. So besides direct-to-consumer genetic tests, then, where else can patients turn for information about their own personal genetics? Well, for some people who meet criteria, this is an option to make testing a little bit more accessible. So this isn't a private pay test. This is something that the Hereditary Cancer Program in BC is doing to what they call mainstream genetic testing. So people who meet certain criteria can actually have multi-gene panel testing ordered for them by healthcare providers outside of the Hereditary Cancer Program. So many of you may be aware of this already, but GPs, other specialists can order the testing directly rather than having to refer their patient to the Hereditary Cancer Program. In my example, Jamie might not have quite met criteria for that. So what other things are available for her? Invitae is the name of a genetic testing lab that is a private pay genetic testing company that does require physician sign off on test orders, but they provide testing for genes associated with increased risk of cancer as well as cardiovascular disease. And then this is a really great initiative based out of Women's College Hospital in Toronto, which aims to make BRCA1 and 2 screening more widely available. So this would not require a physician to order. A person or a patient could self-refer themselves as long as they're Canadian and over 18 years of age. They can participate. They pay out of pocket for the testing, and they can find out if they carry a mutation in one of these genes. So I've linked to all of those resources there, and we'll acknowledge that this is now a lot of talk about hereditary cancer for a reproductive medicine symposium. I'm going to turn it over to my colleague Jessica to switch gears for us.
Thanks so much, Diane. Oh, perfect. Okay. Thank you so much, Diane. So as Diane said, I wanted to switch gears here and talk a little bit more about genetic testing for reproductive purposes and talk about carrier screening. So of course, I'm sure this is familiar to the audience, but Carrier screening is a genetic test that identifies if you carry a gene with a variant that can impact your child. So carriers are typically healthy, but we're going to talk more about, we're going to come back to that topic. So what's missing from this field? Of course, we see access as an issue. So the cost of the test is quite expensive, and then just providers out there that are actually offering this test to the public. And then, of course, education and public awareness. So there are many different companies out there offering this test. We work most closely with Natera, which offers the Horizon carrier screen, but there are many different options. So as Diane had mentioned, we last did this talk in 2019, and I wanted to illustrate how the field has changed even since then. So when we're talking about carrier screening, we frequently talk about expanded panels. So expanded panels are just tests where we're looking at hundreds of genes at the same time. And you can see in 2019, Fulgent was offering a carrier screen of about 320 conditions. Now we're looking at 787 conditions. Invitae was a fantastic provider of this test, but unfortunately they're no longer offering that comprehensive carrier screening. And you can see Horizon has more than doubled their panel. So this landscape is definitely changing quickly. So of course, when we're talking about carrier screening, we need to discuss autosomal recessive inheritance. I'm sure this is familiar to this audience, so I'll be brief. But if we have an egg and a sperm that are a carrier of the exact same genetic condition, and of course it doesn't matter if it's different, we see a 25% chance to have a child affected with this condition, a 50% chance to have a carrier child, and a 25% chance to have an unaffected child. So just because your patient doesn't have any family history of a genetic condition, of course, doesn't mean that they are not a carrier of a genetic condition. So then we have X-linked recessive inheritance. When we're talking about these expanded panels, usually there are quite a few X-linked recessive genes on there for females. We're not doing this testing in males for the X-linked recessive conditions because they would only ever be affected and can't be a carrier. So if we have a carrier egg, we see a 25% chance to have an affected male, a 25% chance to have a carrier female. Carriers are typically healthy carrier females, although they can show symptoms due to skewed X-linked inactivation. And then we have a 50% chance to have an unaffected male or female child. So this is completely normal. We are all expected to carry at least a few recessive conditions, and I've just listed a few that you might have heard of more frequently, like cystic fibrosis or sickle cell anemia, for example. Wanted to provide a little bit of perspective on this testing. So we know in the prenatal kind of reproductive realm, screening for Down syndrome can be a topic that comes up quite frequently. So if we look at a 35-year-old, we see about a 1 in a 356 chance to have a baby born with Down syndrome. Whereas if we're looking at these genetic conditions, we see about a 4% chance to identify a reproductive risk of a severe condition. So that means that we're seeing two unrelated people who carry the same condition or a female carrier of an X-linked recessive condition. So that number is from Invitae. iGenomics reports about a 5% chance of identifying this reproductive risk. And Invitae even said they found up to a 30% chance to identify a reproductive risk for a more mild condition. So we're seeing at least a 1% chance for a couple to have a child with one of these recessive conditions, because of course, if we identify that risk, they have that 25% chance to have an affected child. We see inherited disorders represent 20% of the causes of infant mortality in developed countries, and the WHO also reports that for 1,000 births, we're seeing 10 babies affected with these types of conditions. So the SOGC and the CCMG published an opinion for reproductive genetic carrier screening. Now this was published in 2016, so it is quite old now, and it is currently under review by the CCMG, or the Canadian College of Medical Geneticists. So hopefully we'll have a new publication soon, but currently this is all we have. So one of their main recommendations is that a discussion should be had with all of your patients planning a family, so preconception testing, or any of your patients who come for a prenatal visit, regardless of gestational age. However, if we're talking about offering these tests to our patients, we need to consider that not all tests are created equal. So we wanted to highlight that point. which also focuses a little bit on the direct-to-consumer testing that Diane was mentioning. So we have 3 options here. We have a direct-to-consumer test like 23andMe, we have our local clinical lab, and we have a private panel like Horizon. So the tests vary in what they're looking for. The direct-to-consumer test is only testing about 29 variants. We're seeing 130 variants at our local lab, whereas that private panel is doing full gene sequencing, including deletion and duplication analysis. So that will really affect the detection rate. So at the lowest, we see 55% detection rate in the Asian population. With the direct-to-consumer testing, we can see up to 99% detection rate in that private panel. So of course, this affects the residual risk. So if your patient had 23andMe testing for cystic fibrosis, they might get a residual risk of something like 1 in 110 chance to still be a carrier. Of course, this is assuming no family history. Whereas if they had an expanded panel that did that full gene sequencing, deletion, duplication analysis, we're looking at very low residual risk. So for someone who's Caucasian, maybe 1 in 2,000 or less than that. So we can see quite the difference there. This was another example I wanted to highlight just because it struck me when I was looking at their testing. So this again is 23andMe. They report a carrier frequency of 170 for autosomal recessive polycystic kidney disease. And in the fine print of their test, they say special considerations. This test does not include the majority of variants that cause polycystic kidney disease in most ethnicities. So then that makes me wonder why they're offering this test. You can see the frequency of variants detected in their customers is about 0%. And they do quote a post-test carrier risk of they say it's unknown, but I'd say it's pretty close to the pre-test carrier risk since the frequency of their variants is pretty close to 0%. So this can definitely provide some false reassurance, especially if someone has family history of this. Whereas if we look at Horizon, that does a full gene sequencing, we're seeing residual risks very, very low. For example, in the Caucasian population, 1 in 9,000 or less than that, general population, less than 1 in 14,000. So in our experience, for carrier screening results, we're seeing that most people are identified to be carrier of at least 1 condition. Typically, we're seeing 3 or 4 conditions, or sometimes more than that. And when we're talking about these results, there are definitely some important points to consider. So manifesting carriers is coming up more and more often. So this means that they may have mild features of the disease or phenotypes associated with carrier status alone. So there was a large study that was done, including 4,000 or over 4,000 subjects, and they found a rate of about 10% had at least one unexpected finding, including these manifesting carriers. So this is a bit of a busy table, but just to illustrate that point, you can see the condition on the left, the references, and then the implications for carrier status alone for those conditions. So we see increased risk for breast cancer, ovarian insufficiency, emphysema, prolonged bleeding times. We also see pro-clotting disorders coming up frequently, like factor V Leiden. So that just illustrates an important pre-test counseling point, is that although this test is really done for reproductive reasons, we can find some information out about your patient themselves. We can also get unexpected results. So conditions that have more mild phenotypes might be detected, like triple X syndrome or Klinefelter syndrome can come up from these tests. We talked about the importance of that residual risk. Of course, we're not including all genetic conditions on this test. And some patients might have had a variant of uncertain significance, but those are typically not reported by these labs. So as data changes and is getting collected and the interpretation of these variants changes, we might then get a report saying, well, now your patient is actually identified to be a carrier of this condition, which wasn't previously reported. So what happens if you have a couple that has this reproductive risk identified? They have a few options. They could do pre-implantation genetic testing. They could consider donor sperm or egg. They could look at prenatal diagnosis options, or of course they could choose to do nothing. So if you're interested in ordering these tests for your patients, there are lots of different options out there, as I already highlighted, and all of these companies would be happy to work with you to set up an order providing order portal and help you negotiate price and sort this out so that you can offer it to your patients. So I did want to end our discussion on carrier screening there and just briefly highlight our prenatal screening services at PCRM. I know we're short on time here, so we do have more information on our website. We do first trimester screening, preeclampsia screening, and non-invasive prenatal testing. Briefly, I wanted to highlight NIPT because this has come up more frequently where we're seeing atypical findings. So that means we're seeing a sample with abnormalities beyond the scope of the test. So this means we could find something out about mom instead of baby. Of course, that's not the purpose of the test, but it does highlight a pre-test counseling point as well, that this test is done on a mixed DNA sample of mom or carrier and placental DNA. And one thing that is very important that has come up in terms of these atypical findings is the possibility to identify maternal malignancy. So we know that cell-free DNA is shed by cancer cells during apoptosis, and this can lead to a specific pattern on NIPT where the lab is going to send you a report that says this is suggestive of maternal malignancy. So if you get a report that says that, it's really important to take that seriously. I talked to some genetic counselors that offer the panorama test, and they said that 2 out of every 3 of those reports they send out lead to a clear diagnosis of cancer in the mom. So those are significant. And there is a study that's actually researching this called the Identify study. And any patient who's had an NIPT that's an atypical result or even a non-reportable NIPT, and they have found no indication of issues in the baby, they are eligible for this test, even 2 years postpartum. As long as they can get into the states like Seattle, all their costs would be covered for this test or this study, and they would get a full body MRI, full workup to try and sort that out. Some resources we wanted to quickly mention. If you haven't heard of the Gecko website, definitely check it out. It's fantastic for all genetic topics. They have something called Gecko on the Run, which is great for just really short form, important points about various topics, and they have more in-depth resources as well. And there are private genetic counseling services out there if you feel like that would be helpful for your practice. Great, thank you so much.
Thank you so much, Diane and Jess, for that talk. It's obviously a huge topic. I want to make sure that we get to Dr. Justice in a timely fashion. Let's just address one of these questions. This says, I generally only formally recommend Harmony or Invitae if the patient or partner have a family history of genetic abnormality, one that is tested for with those tests, or if they have unknown family history, like adopted. For other patients, I just say Harmony and Invitae is optional if they have the funds or interest, and only if testing would impact their decision. Do you think this is reasonable, or should it be recommended to everybody despite the cost?
So I was reading this question while you were talking, Jess, so I've had a minute to think about it. So it sounds like the question is about NIPT. Harmony is a brand of NIPT, and Invitae used to offer NIPT, but they no longer do. I would say that this is testing that should be offered to everyone. It doesn't necessarily mean that they have to do it. Like you said, if they're going to do something different with the information, if knowing that they're at an increased risk for having Down syndrome in their pregnancy, if they're going, that's going to affect the management of their pregnancy, absolutely do this testing. If they're comfortable paying for the testing, like all of these things, that's the patient's choice, and they should make an informed choice about it. I would say, though, that family history has nothing to do with whether you should do NIPT. NIPT is for sporadic genetic conditions, Down syndrome, trisomy 18, trisomy 13, microdeletion syndromes. I shouldn't say nothing to do with family history. There are some cases where maybe a microdeletion syndrome is inherited from mom, but for the most part, these are sporadic conditions, and family history shouldn't be the indicator for whether someone does this test.
Thank you so much. And then maybe, Diane, what I can ask is in the chat, maybe if this question was asking about expanded carrier screening, maybe you could answer that in, I'll leave it here and you can type the answer. And then Jess, could you just clarify, somebody's had a glitch and they wanted to know what the Identify study, who to direct to look into the Identify study?
Yeah, so I would honestly just Google it, or I can send the link for the Identify study. There's a genetic counselor listed on their contact page there. I called her to find out more information and prep for this talk, and she answered, and she was fantastic. So she would be able to connect you with any of those resources. But she did tell me as long as patients can get into the US, all costs are covered for them, and a companion, which I forgot to mention.
And last question, carrier screening for patients with Ashkenazi Jewish background. If so, having one, it says grandparent, but maybe they mean parent, or if it's a grandparent, like who should you offer the Ashkenazi Jewish screening to?
I would say if they have Ashkenazi Jewish ancestry, then any ancestry, they should all get carrier screening. I mean, our take is that carrier screening is relevant for everyone, regardless of their ancestry, especially because we're seeing so much mixing of backgrounds. But definitely any Ashkenazi Jewish history is relevant for sure.
Perfect. And then there is a question on there about harmony and vitae and false positive rates. So maybe you could answer that in the chat.
Sure.
Sorry, in the question box. Perfect. Okay.